All right, well, good evening, everyone. I wanted to welcome you all to this year's Nebraska Association of Pathologists Fall Virtual Meeting 2021. Pre-COVID, the NAP would meet twice a year to discuss different topics in pathology. And this year, due to the pandemic, we have been able to pivot to a virtual setting until we are able to meet in person again. With this format, I just wanted to go over a few housekeeping items. First, as we're using Zoom, you can find all of your webinar controls by hovering over the lower section of the Zoom screen. You'll find your microphone, your webcam, and chat box options, among other things. Please make sure that your microphones are muted throughout the meeting. And if you need to ask questions, please use the chat box or wait until the Q&A portion of our event. To unmute yourself and ask your question. We'll address all questions at the end of each presentation. You can also use the chat function to send messages privately to individual attendees. If you have technical difficulties, please close your browser and use the link to access the webinar once more. Otherwise, feel free to send me a message via email. The resident presentations are being recorded and will be shared with attendees at a later date. And we do encourage the use of webcams if you are able to, in order to help us have just a more face-to-face atmosphere during the meeting. And if you're able to rename yourselves to your names, that would also be helpful for us to know who's on our call. And with that, I'd like to welcome Dr. Jean Thompson, our NAP president, to say a few words.
Thanks, Carmen. Sorry for the delay. I'm at work and I don't have a camera, so I apologize, but look at that lovely picture. Here I am. To reiterate, thank you for attending. We are doing the resident presentations, and it sounds like we've got a good lineup for the evening. We have a couple sponsors that we are going to hear from. Caris Life Sciences and Astellas are with us this evening. And we are going to open with a sponsor segment by Caris Life Sciences.
Thank you, Dr. Thompson. And here's our agenda for tonight. I want to thank this evening's exhibitors and encourage you all to visit their booths on the virtual platform. And I also wanted to remind you to use the virtual platform to visit the exhibitor booths. You can chat with the company representatives live, so make sure to take advantage of that opportunity and thank them for their participation. Without their support, our organization would not be able to carry out its mission. And for our next segment, we want to thank our industry partner, Caris Life Sciences, and welcome to our fall meeting. With that, I want to move on to the next segment and introduce our first speaker, Dr. Ahmed Sabri. Dr. Sabri is a PGY2 resident physician, a QI and HSC representative for the Department of Pathology at Creighton University, past research scholar at UC San Diego Health, the University of Jordan alumnus, class of 2016, and an aspiring hemopathologist and surgical pathologist. He envisions his career as an academic pathologist. He enjoys traveling and trying new food, just not veggies. And he was born and raised in Jordan. He's a father of his new buddy, Imran. Thank you for joining us today, Dr. Sabri.
Oh, thank you. So today I'm presenting a case and a short overview of an associated hematologic neoplasm. These are the Ignatian values in medical education. And this is my disclosure. Acknowledgement go to Dr. Cantu, Dr. Davi, and the Monroe Meyer Institute for their contribution and helping me organizing this presentation. So I will start with the patient history and physical exam. We had an 83-year-old male who presented for an incidental increase in total protein in 2018 and the monoclonal gammopathy in 2020. The past surgical history and past medical history showed cardiovascular diseases, DM, stage 3 chronic kidney disease. On the physical examination, this patient was pale and mildly fatigued without any lymphadenopathy. Looking back at his CPC since 2018 shows that this patient has been anemic, and then the most recent urinalysis done at the first visit showed increased total protein levels. Moving on to the comprehensive metabolic panel showed that this patient has been having chronic problem of increased protein levels. And the patient was recommended to follow up with the hem-onc, but he did not. Later on in 2019, the patient presented with a similar presentation, and then at this time, he decided to do serum protein electrophoresis, and it showed like an increased monoclonal proteins at the gamma region with a 2.5 gram per deciliter. Again, the patient was recommended to follow up with the hem-onc, but he did not. Next time in 2020, the patient present with the similar findings and again monoclonal protein, and he follows up with the hem-onc. The hem-onc was really thinking of probability of progression of MGUS to multiple myeloma or plasma cell myeloma. So kappa quantitative measurements and lambda quantitative measurements were done and showed increased kappa to lambda ratio with more than 100, and then increased kappa concentration. The management plan for this patient was a bone marrow biopsy, FISH, cytogenetics, flow, and imaging. The imaging did not show any abnormal bone marrow signals to suggest a multiple myeloma. So we start with the bone marrow aspirate smear from this patient. And as we were looking through the bone marrow, we noticed that we're having normal lymphocytes. And then some of them are actually having a plasmacytoid morphology. And then we have a scattered plasma cells. The count showed an increased lymphocyte count, and then those scattered the plasma cells. Additionally, on the bone marrow aspirate, we saw a lot of scattered mast cells. And then the CD117 is just highlighting here the bright mast cells compared to the dim immature myeloid precursors. Moving on to this patient bone marrow core biopsy, it showed an aggregates. Some of them were interstitial and some of them were hugging the bone, which is called paratrabecular aggregates. And then moving at a higher power to look at those aggregates, again, we saw that those aggregates are composed mainly of lymphoid lineage. Some of them have plasmacytoid morphology, and later on the stains revealed also scattered the plasma cells in those. So CD20, so on the stains, CD20 was composing the majority of those paratrabecular aggregates. CD3 was only scattered, and again, CD138 was only scattered. Clot section is just showing the similar findings of lymphoid aggregates. And then stains were done again on the clot section, and again showed majority of CD20 cells. CD3 was scattered. CD138 was scattered, and it showed the kappa restriction along with some polyclonal plasma cells. It's important also to note some negative stains, which were CD10 in those B cells, BCL6, CD5, and BCL1 or cyclin D1. Seems like I'm stuck. Hello?
We can still hear you.
Oh yeah, okay, yeah, this moved again, okay. So the flow cytometry were consistent with the bone marrow finding, and it showed the kappa restricted plasma cells. And then we saw CD20, CD19 clone of B cells that were kappa restricted and were CD23, CD10, and CD5 negative. The karyotyping of this patient showed just a normal male chromosome component 46XY. And then the FISH cytogenetics showed a non-specific finding. On the left picture, we can see like 3 copies of 13q14 with the red color, and then 2 copies of the green color 13q34. And then on the right side, there was a partial deletion of IGH at 14q32 locus, and then additional loss of 1 copy of 14q32. It's also important to note that none of small B cell lymphoma translocation were present in this patient, such as translocation 1114, 1118, and 1418. Serum immunoglobulins and immunofixations were done, and it showed decreased IgG level with a very high IgM level. And serum immunofixation showed IgM monoclonal pans, IgM kappa pans. And then a serum viscosity was done, and it showed hyperviscosity in the patient. The molecular testing for MYD88 mutation was ordered and it was detected. So in summary, we have an elderly patient who presented with fatigue and lymphadenopathy. The comprehensive metabolic panel and urinalysis showed increased protein levels. Serum immunoglobulin, immune fixation electrophoresis, and serum protein electrophoresis showed IgM kappa monoclonal pans with increased IgM levels. Hyperviscosity is present in this patient. A bone marrow biopsy showing paratrabecular interstitial aggregates of CD20, CD5 negative, CD20 positive, CD5 negative, CD10 negative B cells with a plasmacytoid morphology and kappa restricted plasma cells, along with scattered mast cells. The flow findings were consistent with the bone marrow finding, and the FISH just showed non-specific findings. And MYD88 molecular mutation was detected in this patient. This led us to favor the diagnosis of a lymphoplasmacytic lymphoma, Waldenstrom macroglobulinemia. So I'll talk a little bit about this entity. By definition, the criteria, it's small B lymphocytes, plasmacytoid lymphocytes, and plasma cells. It's involving the bone marrow and sometimes lymph nodes and spleen. And it doesn't fulfill the criteria of any other small B cell lymphoid neoplasms that can have also plasmacytic differentiation. Now, the distinction between lymphoplasmacytic lymphoma and other differential diagnoses is not always a clear cut, particularly marginal zone lymphomas. And this is why some cases need to be diagnosed as a small B cell lymphoid neoplasm with plasmacytic differentiation, and then you just provide the differential diagnosis. The postulated cell of origin for this entity is a post-follicular B cell that differentiates into plasma cell. MYD88 mutation is detected in more than 90% of cases, but this is not specific required for the diagnosis. It's often associated with IgM paraprotein. Again, this is not specific because some patients present with IgG or IgM and IgG. Now, cases of gamma heavy chain disease are no longer considered a variant of LPL, and Waldenstrom is defined as lymphoplasmacytic lymphoma with bone marrow involvement and IgM monoclonal gammopathy of any concentration, and this is basically our patient. The epidemiology, it's more common in adults, with the median age at the 7th decade, and then a slight male predilection. The localization, the most common site is bone marrow, and the other sites could be lymph nodes, extranodal sites, and peripheral blood. Bing-Neill syndrome is basically central nervous system involvement of the lymphoplasmacytic lymphoma. And then it's also important to note that patients who present with hepatosplenomegaly and adenopathy have a higher proportion of disease progression and deterioration. For the pathogenesis and the pathophysiology, we have three main phenomena. The simplest one is just a predisposition, which is AMGAS annual progression to LPL at 1.5%. And then chronic immune stimulation. The literature had showed an association with certain autoimmune diseases, such as autoimmune hemolytic anemia and Sjogren syndrome, and some infections such as rickettsia and hepatitis and HIV. And finally, the genetic and molecular factors. We have familial clustering in about 20% of cases. We have an activating mutation that promotes cell survival and proliferation, which is MYD88 mutation. And this is detected in more than 90% of cases. We have 6q deletion, and this is the most recurrent cytogenetic abnormality. And at this deletion, we lose certain tumor suppressor genes that are involved in B cell proliferation and cycle. And then we could have other cytogenetic abnormalities that are not specific, such as P53. And then CXCR mutation, it almost always exists with the MYD88 mutation, and it had a role in the progression and the drug resistance. Then the clinical features. We have anemia and we have paraproteinemia. Anemia, usually the patient had weakness and fatigue. And for the paraproteinemia, we could have hyperviscosity or cryoglobulinemia. And this is due to IgM having cryoglobulin activity, or it just acts as autoantibody against cryoglobulin. Cold agglutinins are due to IgM. Neuropathies are due to IgM against myelin sheath proteins. And then diarrhea has also been detected in some patients due to IgM deposits in the GI tract. And coagulopathy due to IgM activity against a clotting factor, platelets, and fibrin. For the microscopy, in the bone marrow, we could have a diffuse, paratrabecular, interstitial aggregates of small lymphocytes, plasmacytoid lymphocytes, plasma cells, and mast cells. It's also important to note that clusters of plasma cells can be formed alone in this entity. Peripheral blood will show similar spectrum of cells, and the white blood cell count will be lower than CLL, which lies in the differential diagnosis. The lymph nodes and spleen will show a monotonous lymphoplasmacytic infiltrate with a variable growth pattern that can be follicular or nodular with diffuse effacement. And then associated amyloid or other immunoglobulin deposits and crystal storing histiocytes. And spleen usually show red pulp infiltrates. Sometimes there's a possibility that this is not LPL, and this concern should be raised when you're seeing proliferation center, and this guides toward CLL, SLL, and a pale appearing marginal zone type differentiation, this guides more toward marginal zone lymphomas. Or sometimes this lymphoplasmacytic lymphoma could be progressing to a higher grade lymphoma, and this should be raised when you see prominent large transformed cells. These are just the findings that we saw earlier in the same patient. Like we just see those plasmacytoid lymphocytes scatter the plasma cells and then the lymphocytes. And these are the famous intranuclear inclusions called Dutcher body. And again, this just shows another Dutcher body. Now the immunophenotype is really important. The lymphoid cells will be positive for surface immunoglobulin, and they will express cytoplasmic immunoglobulin. All of them except usually IgD is not detected. Light chain restricted, they will be CD25, CD38, and B cell associated antigen positive. They will be negative usually for CD5, CD10, CD103, and CD23. It's also important to note that CD5 positive or CD10 positive cases have been detected, but it's also important to note that those cases usually are BCL1 and BCL6 negative, and CD23 positivity can also be detected. Then the plasma cells. Usually those will be CD138, CD19 positive, and CD45 positive, and this in comparison to multiple myeloma or plasma cell myeloma. In our case, CD45 was negative. Then PAX5 also will be positive. Plasma cells will be negative usually for IRF4, MUM1, and only IRF4, MUM1, but it also can be positive. It's also important to note that IRF4, MUM1 negativity and PAX5 positivity can also help in differentiating this from marginal zone lymphoma. And it's also important to note that this phenotype may change over time. And I'm stuck again.
We can still hear you.
I know I'm still like in connection, but seems like it's loading. Okay. So then for the outcome, the prognosis, this is an indolent entity, but incurable, and the median survival is between 5 to 11 years. The relapse is almost inevitable, and many adverse prognostic factors may play a role, such as the age of the patient, certain cytogenetic abnormalities, levels of hemoglobin, platelet, microglobulin, and monoclonal IgM. The main disease-related cause of death can include disease progression and transformation to high-grade lymphoma and complications of therapy. For the treatment, there's no standardized treatment, and asymptomatic patients are usually managed with watchful waiting. Treatment can be initiated with certain symptoms, and then treatment regimens can be single agents versus combination strategies. And these are the agents, and usually the combination strategies will include the monoclonal antibodies along with one of these. The plasmapheresis is for patients with hyperviscosity, splenectomy for chemotherapy-resistant patient, and stem cell transplantation is for refractory patient, usually autologous stem cell transplant, and then allogenic stem cell transplant when there's no other option. And some investigational therapies are directed against certain mutations and cluster of differentiation. And finally, the differential diagnosis, and this is like very important. We have AMGAS, and this could be IgM, and IgM AMGAS is usually closely related to LPL and is considered likely a precursor lesion. MYD88 mutation in IgM AMGAS is sometimes detected, and then usually there will be no end organ damage with AMGAS. IgG AMGAS, on the other hand, usually are MYD88 negative, and it's more related to plasma cell myeloma. Then the plasma cell myeloma, some rare cases are IgM positive, but this will present with a different clinical presentation. And most importantly, this will be only plasma cells. And then the immunophenotype usually will show CD19 and CD45 negative. Then the marginal zone lymphoma, and this can be extremely challenging, but usually marginal zone lymphoma do not show like MYD88 mutation. Still, it can be detected sometimes. Additionally, paratrabecular aggregates point more toward lymphoplasmacytic lymphoma rather than marginal zone lymphoma. And then marginal zone lymphoma will more likely present with lymphadenopathy, which wasn't the case of our patient. And mast cells also, which were present in our patients, are more likely suggestive of lymphoplasmacytic lymphoma. And then the symptoms such as hyperviscosity are not common in marginal zone lymphomas such as lymphoplasmacytic lymphoma. Then we have the CLL, SLL, and here we have the proliferation center, which is suggestive of CLL. And then usually those cases will be CD5 positive, CD23 positive, and MYD88 mutation negative. Then the mantle cell lymphoma, which can show paratrabecular aggregates, but usually will be CD5 positive and cyclin D1 positive. Or cyclin D1 positive is usually sensitive for mantle cell lymphoma. SOX11 is positive and specific, but again, more likely it will be MYD88 mutation negative. And then it will have the famous translocation 1114. And finally, the follicular lymphoma, which could also present with a paratrabecular aggregate. But this entity usually will be CD10 positive and BCL6 positive. And in our case, it was negative. And then it will have the famous translocation most of the time, 1418. And then more likely it will be MYD88 negative. And then this should conclude my presentation.
All right, thank you so much. Are there any questions for Dr. Sabri? And feel free to either unmute yourself or type those up in the chat box.
I have a quick question. Because marginal zone to me is the one that is most scary for this diagnosis to miss. Do you know, is there a significant difference treatment-wise between marginal zone and this diagnosis?
I don't know, honestly, like if there's a different in treatment. No, I don't know.
Are there any other questions for Dr. Sabri?
The question regarding this particular patient presenting, degree of hyperviscosity. You mentioned he was hyperviscous, but what also strange about him, he's been hyperviscous for about a year, since the original presentation, until he decided to follow up. how this hyperviscosity was clinically manifesting.
I mean, the hyperviscosity in this patient, I mean, we saw in the peripheral blood, and then we saw also in the bone marrow aspirate smear, which I didn't show here. We saw some platelet clumping, but then like to suggest other symptoms such as like diarrhea and those stuff that I already presented, they were not present in the patient. It's just the degree of the serum viscosity testing. And then the other thing is just like the platelet. The platelet count was normal though, but I mean it was noticeable in the bone marrow aspirate and then the peripheral blood that this patient is having platelet clumpings.
Yeah, I have a question. This is Derek Lester in Lincoln. Back when I was a resident, back in 1896, I did a talk when I was a second-year resident on, I titled it Waldenstrom and Amy Lloyd, An Unusual Marriage. And it was a case of amyloidosis associated with Waldenstrom macroglobulinemia. And I'm just wondering, did you do an amyloid stain on this case and or just look for the vessels?
No, we did not do amyloid stain. We did not do amyloid stain on this case.
I mean, it's pretty unusual, but I just was curious.
Yeah.
Do we have any additional questions? All right, seeing none, Dr. Sabri, thank you so much for sharing your time with us and this interesting case.
Thank you.
And I now want to introduce our second speaker, Dr. Pranav Ranavikar. Dr. Ranavikar moved to the United States after graduating medical school from India. During his research years at the University of Iowa, he studied the regulatory mechanisms of autoimmune diseases. Now, as a PGY2 in pathology at UNMC, Dr. Ranavikar enjoys working in each subspecialty as an undifferentiated resident with potential interests in surgical, pathology, hematopathology, and immunology. If he is not at work, he is either napping or at the gym. Thank you for joining us tonight.
Thank you for the introduction and a very good evening to all. I guess I'll start sharing my screen. If you all can see 1 versus 2. Is it a one screen for everyone?
It's on presenter mode
presenter
right
view.
now.
Okay.
Yep. There you go.
Okay. All right. So I heard Dr. Lester's comment about him being a PGY2 in 1896. And now since I'm a PGY2 in 2021, I have to talk about the comparisons of histomorphology versus the molecular stuff that evolved in the last few decades. So my study today, it was done with Dr. Lele here at UNMC. It's titled Pathology Database Risk Group Stratification is equivalent to that obtained by Oncotype DX testing in prostatic adenocarcinoma. So this was a comparative study between how we stratify risk groups for prostatic adenocarcinoma using surgical pathology on one side. And these days, we also send some of the biopsies for Oncotype DX testing and what that risk group calls it and if there's any difference in the eventual outcome or the eventual follow-up of the patient. So the background, prostate cancer cases that are diagnosed as a Gleason score 3+3 or a 3+4 on needle biopsy are frequently referred for gene expression studies, mainly to confirm or validate the risk group categorization. This risk assessment will help to determine prognosis and also in therapeutic decision-making. Some of the traditional risk assessment tools include serum PSA, the Gleason score, and the clinical stage. So I'll go over the basics of the Gleason score first. If we look at Gleason pattern 3, some of the adjectives that we have in our mind are well-formed glands, back-to-back glands. They could be either uniform or variably sized, but these are some of the examples of pattern 3 that we see. Next, we go to pattern 4. In pattern 4, we see small fused glands. They could be poorly formed, they could be large, and importantly, cribriforming is also included in a pattern 4 Gleason score. The next pattern is Gleason 5, where we see sheets or nests or cords, and in some cases, comedonecrosis. So when we report these patterns out, we report a primary pattern and a secondary pattern. And there's a slight distinction between how we do it on a radical prostatectomy versus a biopsy. In a biopsy, we usually, the secondary pattern is always the worst pattern reported, whereas in a radical prostatectomy, we have the criteria for 5% tertiary pattern as well. So now about the PSA. Clinically, the traditional cutoff for PSA is 4 nanograms per mil. However, the level above 4 nanograms has a sensitivity of almost 20%, but it's more specific, about 60 to 70% for prostate cancer. Some of the other parameters that the clinicians like to look at is the PSA density, which is the PSA, serum PSA per prostate gland volume. More than 0.15 would prompt a biopsy. Importantly, there are age-specific ranges with a higher PSA that's allowed for older individuals. And PSA velocity is another criteria that the clinicians use, which is a change in PSA value over time. So an increase of more than 0.75 per year would prompt a prostate biopsy. So now we have the traditional mechanisms of understanding risk stratification. And in order to complement the conventional tools, the Oncotype DX assay was developed. This is a multi-gene RT-PCR assay that utilizes biopsy tissue and measures expression of 12 cancer-related genes and 5 reference genes. And they give the genomic prostatic score depending on studying those genes. And that score is used as a predictor of aggressiveness for that cancer. It typically ranges from 0 to 100, and the genomic prostatic score would also stratify a prostate biopsy into different groups, which I'll talk about subsequently. But the major pathways that the GPS looks at is the androgen pathway, which involves these 5 genes, the cellular organization pathway, another 5 genes, and proliferation and stromal response. When this assay was developed, some of the key challenges that they had was the heterogeneous nature of the cancer itself. And frequently, at first diagnosis, we have a very low volume tumor to diagnose. But the company has done a pretty good job at validating this test even for very minute tumor samples. So the National Comprehensive Cancer Network and even the US Preventative Task Force place an emphasis on avoidance of overtreatment. So they have come up with risk stratification groups, and they get updated pretty frequently. So this is the 2019 update of the risk stratification group for prostate cancers. Very low to low group risk includes a T1 to T2A lesion, a Gleason score 3+3, and a PSA less than 10. So these 3 are the predominant variables included to calculate the risk. Here, T1 or T2 are the clinical stages, where T1 is biopsy identified, T2 is organ confined disease, and they have separated A, B, and C according to if it's there in one lobe or two lobes. And then depending on if the patient falls in very low to low, then the clinician determines active surveillance on that patient. Every institute pretty much have their own way of the active surveillance protocols, but some of them include assessment of serum PSA every 6 to 12 months, or a rectal exam every 6 to 12 months, or even a repeat biopsy. The next risk group includes an intermediate favorable, where the Gleason score is 3+3 or 3+4, but there's a rise in the serum PSA from 10 to 20. And importantly, there's less than 50% positive biopsy course. And this is also favored into the active surveillance category as the first choice of treatment. With each of those, the clinicians typically also offer a radical prostatectomy or some localized therapy, but the to-go therapy for these two is active surveillance. And then once we start going towards the unfavorable groups, that's when we start looking at definitive therapy for prostate cancer, which involves radical prostatectomy, radiation, as well as ADT. And so the distinction between intermediate favorable and intermediate unfavorable is very important to determine if the patient needs to go for active surveillance or if the patient needs definitive therapy. Whereas at the extremes of these groups, it's pretty evident that they are going to be followed with surveillance, or for a high risk, they are definitely going to get some therapy. So our goal is to determine if addition of molecular testing is necessary by evaluating its correlation with the risk stratification that we have using our surgical pathology report and the serum PSA. So on one end, we have the Gleason score, the serum PSA, and the number of positive cores, versus the genomic prostatic score that's given out by the Oncotype DX. So this is how they typically report the genomic prostatic score. They also try and put the patient into the same risk groups. But what would happen is if we give a favorable intermediate group according to our surgical pathology criteria, the GPS score might move it to unfavorable or low or high, depending on what they see on their genomic testing. So we were trying to see if there is any concordance between the Oncotype DX score versus our surgical pathology risk stratification. So we screened almost close to 5,000 biopsies between the last 6 years. And we looked at all the cases that were sent out for Oncotype DX testing after a prostate biopsy. And so the risk group that was predicted by Oncotype DX was directly compared to what we have in our SearchPath report. This is just a flowchart of the design. So this is a comparison between the two risk groups. And if they fell under the same NCCN risk recommended initial therapy group, we called it a concordant result. But if they did not match between each other's results, so it was a different NCCS risk recommended initial therapy group, then we called it a discordant result. So we focused on the discordant cases and obtained follow-up information on those. So 131 out of the 4967 cases, that's 2.6%, were sent for Oncotype DX testing, of which only 113 cases had follow-up information. Of those, we see 83% were concordant, which was good to assess that Oncotype DX is really validating 83% of our cases. However, 17% cases showed a risk group discordance. Now I'll be looking at those 17% cases, and all of them were called out as intermediate favorable by our pathology report and PSA level, which means they were Gleason score 3+4 with a PSA of 10 to 20 and less than 50% positive biopsy course. And in those 17, 16% were predicted as intermediate unfavorable by Oncotype DX, which means we are moving toward a more definite therapy than just active surveillance. So Oncotype upstaged these cases into an intermediate unfavorable, whereas 1% was a high risk prediction by Oncotype. Upon follow-up of those 16%, we saw that the clinicians chose to actively go for surveillance in 11% of those cases. 3% received a radical prostatectomy, whereas 2% got radiation therapy. Once we started looking at the cases that had active surveillance, till date, till 2021, there was no adverse outcome on follow-up. And I will define what adverse outcome means in terms of failure of active surveillance. But in all of those cases, we did not see any adverse outcome on follow-up. There was no change in the Gleason score and the risk group at subsequent biopsies. And this is still, the patients are still undergoing active surveillance. So far, there hasn't been any adverse outcomes or change in the Gleason scores. Then the 3% which got radical prostatectomy, again, there was no change from the previous biopsy determined Gleason score, which means it was a 3+4 lesion. The pathologic stage was PT2, that's organ confined, and the margins were negative. No adverse outcome on follow-up. Similarly, for radiation therapy, there was no biochemical recurrence or adverse outcome. Whereas for the 1% case that was predicted high risk, it received radiation plus androgen deprivation. And even that case did not show any biochemical recurrence. So here, I define what I mean by failure of active surveillance. There's two criteria, the pathologic criteria as well as the clinical criteria. In the pathologic criteria, we should see an increase in the Gleason score that was reported originally, or we should see an increase in number of cores involved. Whereas in the clinical criteria, the clinicians would look at a PSA doubling time. If it's less than 3 years, then that would flag as a failure of active surveillance. Whereas biochemical recurrence, for a prostatectomy, after radical prostatectomy, if the PSA shows more than 0.2 nanograms per mil, about 6 to 12 weeks after prostatectomy, they would repeat the value, and if it shows persistently more than 0.2, then we define it a biochemical recurrence. Whereas after radiation, we need to see a rise of 2 nanograms per mil or more above the nadir PSA. So importantly, for all of our cases, we did not see any adverse outcome on follow-up, and they maintained their Gleason score and they maintained their risk stratification. So to conclude, the risk stratification that's provided by information in the pathology report was equivalent to that obtained by Oncotype DX testing. And in cases where we call it a favorable risk group, Oncotype DX might not provide any additional benefit over the routine pathologic assessment paired with serum PSA in these cases. So this should be it for me. Thank you for listening. I'll take any questions.
All right, do we have any questions for Dr. Ranawikar?
Are your
Hi, this is-
clinicians requesting Oncotype? Sorry for interrupting whoever just started. I apologize. Are you seeing a lot of requests for that though?
Yes, we are, and I'll show you the exact risk group. Oncotype DX has almost, it's been frequently recommended for the biopsies that we call as intermediate favorable. But in the other risk groups, I don't see a lot of recommendations for Oncotype. And I think mainly it's because a distinction between favorable versus unfavorable changes how we would manage the patient. So we are seeing a lot of recommendations for the intermediate favorable group.
Pranam. Hi, Dr. Juil. So excellent presentation. So do they do this in fresh tissue, similar in the same way that that we do that with breast? Like how do they send the specimen?
Yeah, in this Oncotype, they use a paraffin embedded tissue to do the
Okay.
test.
It's not fresh. And who sent that request? Is the clinician, the urologist, the
Yeah, it's the urologist. Once they see our report and once they see that it's intermediate favorable, then they would recommend the Oncotype test to the patient.
And I guess that the insurance covers that. Just guess.
I looked at the costs. It's a $5,000 test, and I don't know if
Mhm.
any and all insurance companies would cover it.
Well, I guess that maybe similar like thyroid and molecular, that most of the insurance, they cover the molecular test if there is like an indication.
Okay. Yeah,
Thank
that
you.
would be interesting to see if all insurances cover it.
Yeah, you never know. Thank you.
Thank you.
Dr. Swanson, I think, was next. Dr. Swanson, have we maybe answered your question? All right, do we have any other questions for Dr. Navikar?
Yeah, I had one quick question. So it's been controversial for years, the role of PSA for, screening for prostate cancer. And, the current CDC recommendations are that men between 50 and 70 are supposed to discuss it with their primary care provider and kind of look at the pros and cons of getting a PSA testing. And the reason is because when they've done long-term outcomes, it hasn't really decreased mortality, PSA screening. Do you think that it's possible that what your study is finding is that, the idea behind that is that, PSA screening finds cancers that are unlikely to cause, death, but, they aren't really finding the highly aggressive tumors before they're already highly aggressive. And so I guess my question is it possible that this finding is just basically kind of, are you just kind of finding out that the low to intermediate grade tumors aren't going to do anything bad anyway?
Yeah, that's a good question. And I think so far I haven't seen any particular changes in terms of screening with PSA. We still see a lot of patients who are screened with PSA after their 50 years of age. But I think the clinicians want to look at the velocity, or they would want to look at the doubling time for PSA. And if we do see a very low or a low grade lesion, then it's unlikely that they would definitively treat it, and they would mostly just monitor it using PSA. So I think the benefit is now more for monitoring than detecting these lesions.
Are you gonna, you're not 50, are you?
Not yet.
Are you gonna get a PSA when you're 50?
Well, I would wait for another NCCN recommendation in the next 20 years.
I'm just kidding around with you.
Yeah, but I mean, I'm saying I don't know yet. We might have something completely new by then to actually screen for prostate cancer. And then when I attend the NAP meeting when I'm 50, I'll say, back in my days when I was a PGY2, we used to do serum PSA.
Whole body scanning.
Do we have any other questions? All right, seeing none. Thank you so much, Dr. Navikar, for
Thank
sharing
you.
your time with us.
Thanks for your feedback and questions.
And with that, I will move on to our next segment, and I want to thank our industry partner, Estelas, for joining us tonight. So welcome to our fall meeting. And with that, we will move on to our business meeting. And so we do have a few updates. our membership is currently at 97, which is higher than when we last met. So thank you all to those who have, spoken with your colleagues or shared our information. I think it's been very helpful in increasing our membership. I also want to let you guys know that the due statements for 2022 have already been mailed out. And so you should be seeing those soon if you haven't already. And so, feel free to check out our website or send your checks to send in your dues. And then we can move on to our financial update. So up on the screen, I've included both our balance sheet and our profit and loss statement throughout the year so far. And as you can see, we are a lot more financially healthy than when we were last year. Just a quick note that at this time last year, we only had $5,046 in our balance sheet. And so, we're almost 3 times as much at this point. And, we've been able to really increase our financial health. Thanks a lot to our industry sponsors. And obviously our increase in revenue from membership dues. And I wanted to make sure that there weren't any questions regarding the financial statements up there. I'd be happy to answer those. All right, seeing none. Just with regards to legislative updates, as you probably know, there's not a lot to talk about at this point, mostly because the legislature is not in session until January 5th. And so there's not a lot going on at this time. There are just some meetings that have been going on with legislators as they try to figure out some of the COVID funding that came during the year. The Nebraska received a few $1 billion. And so the NMA has been involved in, trying to steer those funds to assist with loan repayment for, the loan repayment program that the Nebraska has for those who end up in rural communities. Trying to steer that towards the RHOP, KHOP, and UHOP programs. And so that's where we've been focusing on right now during this downtime. We are getting prepped and looking forward to see what the next legislative session brings. As you may know, it's the short session. So that means that every bill that wasn't voted on from last year gets automatically transferred to this year as still in play. So that includes Senator Wayne's bill to increase your liability cap tenfold. So if there's anybody in Senator Wayne's district, I do recommend that you reach out to him as a constituent and let him know your concerns about doing that. We'd be happy to help with any verbiage too, if you might need that. And so the senators will have 10 business days to submit all of their bills for the year. So by the end of January, we will have a final list of bills, and I'll be able to send any updates on anything that might reflect on physician practice and specifically pathology. I also wanted to invite anybody who can make it to the NMA Advocacy Breakfast. We are hosting that on February 1st in person at 7:30 a.m. at the Hrska Law Center here close to the Capitol. And then I also wanted to just put a plug for LifeBridge, which is a new program at the NMA to help assist physicians with burnout, mental health concerns, divorce lawsuits. The program is confidential. The people who are mentoring you, it's not therapy, it's a mentorship program where it's other physicians working with physicians. There's no insurance, information that's received. We don't really know each other's names. The client gets a number. So nobody knows who the person is except for these mentors. So just wanted to put that out there as something that is a resource for anybody who might need that. And so with that, I wanted to invite Dr. Thompson to provide a CAP update.
Thanks, Carmen. This update is courtesy of Dr. Bober and Dr. Tochmeyer, who actually attended the House of Delegates meeting as I was unable to. So there were several points that they brought up. First, that in July, CMMS again released their 2022 fee schedule, and it did include overall payment cuts to pathology to the tune of about 5%. However, they also, the physician fee schedule for 2022 is supposed to include different pathology consultation codes with a tentative higher valuation than the existing codes that are in place. So I believe that this is more in the just the pathology consultant. Its codes 80503, 80506 are to replace 80500 and 80502. The other thing that they talked about is that CAP continues to oppose a single payer system, and they continue to work on that. The congressional leaders reintroduced the VALID Act of 2021, which has oversight of laboratory developed tests. They don't seem to be able to let go of that, but I don't know that there has been progress in that area. And then the Cigna announcement that they're going to deny claims for professional component of clinical pathology services was discussed. The CAP is objecting to it. I'm honestly not sure what's going on with that at this point. I know I've seen a few things in my email. I have not taken the time to really tease it out. So I don't know if anybody else has any other info about that at this point. But that's a short recap of what was discussed.
Yeah, I can maybe add a couple of words. Regarding this clinical pathology consultation codes, I know that they're underutilized, but the idea is, we have currently two, the complex and simple, but what they will be adding the ability to bill for the extra 30 minutes. You bill, for example, complex consultation case, but if you spend more than 30 minutes, you can add an increment of 30 minutes of billing of this, the pathology, clinical pathology consult code. That's a new, thing which will appear. And regarding the Cigna, originally, the Cigna dropped their position, but it looks like in the last emails, I think coming in October, they want to keep denying it again, and the battle is back to square one.
Thanks for the update.
Yeah, thank you.
Anyone have anything else?
You're welcome.
I'd also like to open it up for any open discussion or questions that you might have about the direction of the NAP.
I think one of the things that it would be helpful to have input on is for the spring meeting. Typically, we have a speaker. Last year, it was a speaker from Iowa, I believe, did a talk on immunohistochemistry. We can go ahead and plan for a spring meeting. We should probably get going on that now. Would most likely have one speaker, and I guess, how does everybody like the virtual as opposed to the in-person? And does anyone have any ideas? I would throw that out there.
All right, so the first feedback we would love to have is whether you feel like we could move back to in-person meetings, or should we remain as doing virtual for the spring?
I would posit that there is value to in-person meetings, especially for mentorship and for young pathologists to be able to meet other people in the field. I think the CAP meeting had a good hybrid model. I don't know if that's possible, but those who showed they were vaccinated could be up in person, but those that still wanted to do it virtually could Zoom in. I don't know how others feel.
I think a hybrid model makes sense. Not everybody could make it to Omaha for the meeting.
I know one of the things that we've discussed about hybrid is that it rather increases costs. I'm not sure where we are on that, so we would have to look into it. I did see some data back from the CAP that indicated that I want to say that they had about a third of the individuals, and it's for the House of Delegates, turned out to the meeting in person, but there were probably still greater than 50% that did not, that attended it virtually.
Yeah, I think it's about right. I think that, there was email summarizing that, yes.
Good points on both ends, though. Thank you. Does anyone have any speaker that they know of that's itching to come to Nebraska in the spring? Or did anyone hear any good presentations? And honestly, if you can't think of it now, to give us a shout out, an email would be appreciated as we move forward.
And even if they can't travel and we do opt for a hybrid meeting instead of a full in-person meeting, we could probably Zoom them in at that point too, if they're not willing or able to travel due to their, institutional restrictions or anything like that.
And I guess that will also check with the members if there is any, I don't know, just thinking like a topic or area that they would like to hear more about, like a AP, CP, surgical, or any specific topic that maybe that we will have to, have like an update, or I think that's something that we also need to consider for that, for the speaker. I don't know, just thinking.
Okay. All right, thank you so much for your feedback. Is there any other point of discussion or area of concern or questions that you guys might have?
I think we're good.
That's great.
Yeah.
All right. Well, guys, can give you back 40 minutes of your evening. So definitely appreciate everyone who joined us today. I want to thank you all for your participation, and I hope that you also enjoyed your time with us. I definitely want to thank both of our speakers for sharing their time and expertise with us, and thank our industry sponsors for supporting today's programming as well. Enjoy the rest of your evening.
Thank you.
Thank you.
Thank you. Thank you for the
Thanks
opportunity.
all. See you in the spring.
Thank you.